Hello and welcome to the Real GI Doc Show. I am your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today on the show, we will be talking about an interesting patient case that was submitted to me from a listener recently. And first I'll play the case, and then I'm going to basically walk through the case in terms of how I would approach something like this as a gastroenterologist. I don't have an answer for this patient. She's not my patient. It's just a question from a listener, but I wanted to use it as an example of how I would think through a case, or how a gastroenterologist would think through an interesting and complicated case like this. So let's play the case. I have an audio file here.
Hello, I am a 59-year-old woman. I'm really kind of embarrassed asking this. I've been to multiple gastroenterologists with no real answers. I have chronic epigastric fullness. Never goes away. I frankly feel like I may have a basar. This started out as a constipation, incomplete bowel movement situation, kind of did some Miralax or whatever, kind of turned to mud. Over the years, I've become more and more laxative dependent. However, I don't even know if this is constipation. I seem to have a very poor motility. At this point, I consult an Ayurvedic practitioner. I often take castor oil because I have to function. I have loads of undigested food. It appears in my stool. Certainly any lettuce that I eat, very poor appetite, hard to eat. It just seems to be getting worse and worse. And again, the hallmark of this is this constant fullness. And I will have asymmetrical bloating and distension while I'm in the...
Well, that's the case. It cut off, and we'll never know the rest of it. But the story, if I had to summarize it, is really one about fullness, bloating, being uncomfortable, having this abdominal distension. And this is actually a pretty a pretty common issue that we see in the gastroenterology practice. And there's a million things that can cause this. This is one of these patient situations that's complicated. It's not a simple, straightforward answer most of the time. Sometimes it is, so how would I work something up like this? And what do I hear from the case when I just listen to the actual case itself? What is that audio message telling me? Well, I hear someone who's had more of a chronic issue than an acute issue. A lot of people come into the office with these kind of complaints, but they're bothering them quite a bit more than you would think when they come in and start telling you the story. And you ask, is this worse than it was recently? Or it's been going on for years and years. Why did you come in today, for example? Did something change? Did something get worse? And a lot of times, the symptoms maybe got a little worse and they've gotten better and they've gotten worse and the patient's just fed up with the whole situation. And you get this story it's been going on for years and years. So it's hard to sometimes tell if it's a chronic or an acute issue. So this sounds more like a chronic issue. She's had several opinions. She's been to several different doctors, several different types of practitioners. She's sought out alternative medicine type stuff. And, when you hear this kind of story of someone getting multiple opinions and presenting with the same problem over and over again, and seeking out all these different opinions, it's one of those things that when we hear this as a doctor, you want to stop for a second and say, why is this person doing that? It's obviously it's because they still feel poorly and they're not getting better. But why are they not sticking with a single person and trying to kind of work up the situation in more of a stepwise fashion? And I don't know. A lot of times I always ask people, why did you jump from doctor to doctor? Because I want to know, was there a problem? Did the doctor not do a good job? Did you find that their bedside manner wasn't good and that's why you left? Or was it that they couldn't figure out what was going on? What were the tests that you had done already? And where are we going to pick up the story? I don't like to reinvent the wheel and do everything that was done already to get the same answers. It's a waste of time. It's a waste of the patient's time. And a lot of times I noticed that people go from doctor to doctor to doctor in the same field, like different gastroenterology doctors, and they don't really progress at all with their workup. They just keep getting endoscopies or colonoscopies over and over again. They're normal, and the patient gets frustrated with the situation because they're not getting any results. So you have to find someone you like and stick with them. It's probably a smarter or better option. The harder thing is just finding someone you like, because a lot of times you just get run through a mill and you get a procedure and we say that's all, there's nothing else that we can do, and then you move on, and that's not great. So, it's good to find a doctor that you can work with. So you may have to search around a little bit, but once you find somebody good, try to stick with them and continue to do the evaluation, because then you can actually get past point A, B, and C and maybe onto something more advanced where you'll figure out what the real problem is. So when I hear all these different symptoms, you want to put it together and think that there's some type of underlying cause. Like, is there it's nice to have one or two unifying diagnoses and not have 5 different things wrong with the person. So when, the hallmark symptoms here really: epigastric fullness, incomplete bowel movements. She didn't get better with Miralax. She's dependent on laxatives for several years, and she's complaining of lots of bloating, poor appetite, abdominal distension. She raises the question, is this a motility issue? Is it a problem where she's not digesting food and she's seeing undigested food in the stool? So we can kind of address these things. And these are all testable hypotheses. You can make a list of things and you can test for them if these are the symptoms. So right off the bat, like, how do I approach a case of like this, like a case of epigastric fullness and incomplete bowel movements and bloating? Because a lot of times it's a common scenario. You hear it. Got to say every day. I got to say, you hear this kind of thing every day in practice. And how do you approach it? So if she doesn't come in with any records, the most important thing is to try to get all the records, because I don't want to repeat stuff that was done already. That's obvious. But let's pretend she walked in off the street with these symptoms, no records, no recollection of what happened. Where would I start? Well, we start by having a conversation. We talk about her expectations, how long this has been going on for. We talk about maybe not doctor shopping and maybe just trying to go through this following algorithm we're going to talk about, and that it might be a process. It might be a process. And from the doctor's perspective, this is what you don't really hear out there, is that as a physician, we don't, a doctor, well, I'm speaking for myself, but as a doctor in general, I don't think doctors love to take on patients that we feel are going to just see us for one visit and then just take off and see somebody else, up the street a week later when they don't get exactly what they need in 5 minutes. So there's that feeling, it goes both ways, that a doctor doesn't always want to put in the mental effort perhaps on a challenging case if we know that the patient's just going to jump ship if we don't give them an answer right away. It's a problem with modern medicine. It's very easy just to jump to the next doctor up the road, and you just never make any progress. Sometimes it takes a while to figure out what's going on. So it's very frustrating from the patient's perspective, and it's frustrating for the doctor as well. So, I try to manage expectations, say like this might take a few weeks or a few months to try to make some headway here, and there might be a whole bunch of tests to do. So let's start with point A. Anyway, what do we do? So there's multiple systems involved here. We start with some basic testing, hopefully some blood work. I'm sure that she had blood work already, but let's pretend she didn't. We would start looking for all the things in the differential diagnosis that we can do with blood work. So in the differential diagnosis, we think about dyspepsia. So this feeling of fullness and discomfort after eating. Dyspepsia could be from something like an ulcer or H. pylori infection or a cancer or something like that, or it could just be dyspepsia as the syndrome of dyspepsia, where you get all the feelings, but you look down there and do an endoscopy and there's nothing major going on. It's called non-ulcer dyspepsia. So dyspepsia is right up on the top of the list. H. pylori, regular old gastritis from something else, medications or stomach acid or whatnot, ulcer disease, gastroparesis, where the stomach isn't moving for some reason, constipation issues, even like lower GI issues often will be the source of all these generalized problems. So constipation issues, irritable bowel syndrome, celiac is always in there in the differential diagnosis. Some type of food or carbohydrate intolerance. She might be sucrose intolerant or lactose intolerant. These are all things you can test for. And there could be something like bacterial overgrowth, which is called SIBO, or there could be pancreatic insufficiency, or there could be some other condition that's more rare than all of these things. And there's also psychological type things that can make people feel this way. Sometimes there is nothing majorly wrong with the GI tract, and this is a manifestation of depression, anxiety, or some other issue. So that's always got to be in the back of your mind as well. And the big thing you have to figure out, or I have to figure out here, is the digestion actually slow and abnormal, or are these constellation of symptoms functional? So functional meaning the plumbing and everything is intact, and there's something going on with the way the person is feeling, or maybe there's something on a microscopic level that we're not going to see on endoscopy, CAT scans, or other testing. Now, if the symptoms are actually due to some type of GI tract abnormality, we have to test for these things and figure out what the problem is. So we make a list, we talk about each topic, and we just work our way down the list. So for this patient, I would start with a diet review, talking about their foods they're eating, what they eat on a regular basis, what kind of things they consume, what things they don't eat, if they're following a certain diet, are they vegans, are they lactose free, do they eat only meat, do they eat only fast food, how often do they eat junk food? These are all questions that you can get a gist of what someone's eating. Sometimes pretty hard to do, so I usually just ask like, hey, what did you eat yesterday, what did you eat the day before? It's hard to get like a long-term diet recall from people, just in general. I don't remember what I ate 2 days ago. Most people don't either. So just kind of like, what do you typically eat in a regular day? And that can tell you a lot about someone's diet, especially if they're having issues with the bowels. If you get a very, very low fiber diet, you can start right there. And I also look at medications, medication lists. Are they on pain medicines? Are they taking iron? Are they taking beta blockers? Are they taking other supplements? Are they taking NSAIDs? All things that can cause major issues with your GI tract. Good to know about. It's always embarrassing when you do $1 million workup and then you find out the person was just taking lots of iron pills or something, and that's why their stomach was upset. So that's always a bummer. So I got to ask about that stuff and look at the med list up front. And then we do some basic lab work. We check the thyroid and celiac disease, and we check vitamin B12 and folic acid and inflammatory markers, CRP, ESR. Whatever you can do with blood work for these kind of cases is great, because sometimes you get something to go after. You get a high inflammatory marker, or you get a celiac antibody that's positive, and then you can go and look into that issue instead of doing 400 tests. And some stool testing, also helpful. So you can check for parasites and giardia, and you can check the pancreatic elastase and all these other things in the stool that are not always tested for. And they're unlikely to find the answer there, but it's unlikely to find the answer in the stool, but it's the way to go. If you can find the answer there, it's great. And then some imaging. So this patient mentioned that she was afraid of having something called a Bezor. And I talked about this in the 4th episode of the show about a Bezor, which is like a retained conglomerate of undigested junk in the stomach that causes like a blockage in the stomach. And these are pretty rare things, but there's a whole bunch of things that can cause a Bezor, and they can cause all kinds of symptoms. So if you wanted to listen to the episode 4 about Bezors, it's super exciting. But you can look at this. You can do a CAT scan. You can find a Bezor. If there's a Bezor there, you can do endoscopy. You can see if there's retained food or vegetable material or something else in the stomach after you do a scan, and see if there's anything going on there. That would rule out a Bezor. So this is a knowable thing. If you feel like you have this thing, there's ways we can actually look into it and answer the question. It's a yes or no question. You could also do what's called a gastric emptying scan. So we can give someone a radio-labeled isotope meal and see how fast things move out of the stomach. It's not a perfect test, but we do them, and they're somewhat helpful in terms of ruling out any type of severe gastroparesis issue, especially if someone is low risk. If this patient has no real risk factors for gastroparesis, she doesn't have some neurologic issue, she doesn't have longstanding diabetes or some other issue, then that would be a good test to do to rule out gastroparesis. She's worried about that. We can test for it. While I'm talking about endoscopy, we do endoscopy. We look for celiac. We take biopsies for H. pylori. You take biopsies of the stomach for precancerous or cancerous type changes. You can see if there's a tumor there. There's all kinds of things you can look for. You can also biopsy the small intestine and do disaccharidase testing. And I talked about this on a recent episode, in episode number 24, about how you can test for the person's ability to digest or to break down certain sugars, which can cause all kinds of bloating issues. You could do that with a duodenal biopsy. So stuff to do. You can know the answer. It's a yes or no question. If that shows us nothing, then we talk about colonoscopy. We want to look at the ileum. We want to check for Crohn's disease. We want to check the colon for inflammation or some type of severe diverticular disease causing a stricture, or colon mass or tumor causing an issue. Is there anything going on there? Knowable stuff with a colonoscopy. And if you need more information on colonoscopy, pretty much every episode on this show is all about the colonoscopy. My favorite test. And what else can you do? You could do bacterial overgrowth testing with breath testing. You could do SIBO testing. You can check for hydrogen. You can check for methane after giving someone lactulose or some other substrate and see what happens. These are things that you can find out. Is someone intolerant to something? Do they have bacterial overgrowth? stuff you can do. It's tedious, it's time consuming, but it's testable. These are testable hypotheses. So what do you do when everything's normal? So let's say this patient went to 3 or 4 different GIs over the years. She had a whole battery of testing, everything that I talked about here and more, and everything was totally, totally normal. Well, now what do you do? This is a problem, and this is what we encounter a lot of times in gastroenterology. These are difficult cases. Sometimes we try sending someone to see a dietitian. Is there some elimination diet you can do? Is there a way to check for food intolerances? These are challenging things to find out. You have to kind of keep like a symptom diary or go on some type of elimination diet. You go on a low FODMAP diet, which I'll hopefully have someone on here to talk about at some point, and a lactose-free diet for a couple of weeks. And you do these experiments, and they're tedious, but you have the rest of your life to figure it out. So it's good to start and do these things. If you haven't had any relief with that, and you've optimized diet, and the patient's exercising, and they're drinking plenty of water, and these things are still not helping, you can start something to help them move their bowels. You can start a prescription laxative. Sometimes we do over-the-counter stuff. She's tried over-the-counter stuff. She's kind of failed it. She's tried stimulant laxatives over the counter, and those can cause their own issues with colonic motility over time. So you want to switch to maybe a prescription laxative. Get them moving the bowels better. Give that a shot for a while. See how much mileage you get with that. Does the bloating get better with a prescription laxative or not? It's worth a try. These are called therapeutic trials. We don't know what's wrong. We've tested for all the bad stuff. We're going to try something now and see what happens. And sometimes people don't like this. They say, oh, you're experimenting on me, but we're not really experimenting on you. These are well-known drugs. They work. They're relatively safe. We're trying to see if addressing problem B fixes symptom C or whatever it is. It's called the therapeutic trial. It's very helpful. We do this in GI all the time. And sometimes the hardest part is just convincing someone that it's worthwhile to try a medicine if they're not fully on board that this thing is going to help them. Because either it does, and then they want to continue it, or at least it gives you some information, or it doesn't, and then you move on. You try something different. They're not married to the medicine forever. These are very low-risk medications. I'm talking about things like Linzess, Amitiza, other medicines to help with constipation. These are all worthy things to try in someone who's having all kinds of bloating and abdominal distension and pain issues. So that's something to think about, a therapeutic trial. Sometimes we try other things, try pro-motility agents. These have some side effects, but something to try. We try digestive enzymes like Creon, something you can give if the patient is not digesting things well and having all these bloating and irritable bowel type issues, and you've tested for everything under the sun. Sometimes you just try Creon and see what happens. Sometimes we try other things. Sometimes if they're having diarrhea, we try different things, try antibiotics and whatnot, but she's not really having diarrhea, so we're not going to do that right now. People try over-the-counter supplements and over-the-counter, what are they called? They're called digestive enzymes. They buy them on Amazon. Do they work? I don't think so, but people try them and sometimes they feel better. And the same thing with probiotics. You try it and you feel better, or you don't and you move on, but at least you tried. And then at the end of the day, sometimes I have to refer someone out to a different type of expert. So someone who's within GI, an expert in something like motility. And they're hard to come by, and it's sometimes hard to get a diagnosis from a motility doctor also, because sometimes there is no diagnosis to be had here. But there's more advanced testing you can do and see if the motility is not functioning properly. Is the GI tract just not moving? So that's a doable thing. You can send someone to a motility specialist. Now, say you've seen the motility specialist and there's still no good answer, then sometimes I shouldn't even say that you don't even have to exhaust every possible thing. Sometimes if the symptoms are giving us lots of anxiety type feel, or there's a lot of depression going on or something like that, or the patient self-identifies with that anxiety is a major trigger, sometimes you talk about that and you either refer to someone who can treat the anxiety if it's a major problem, or you can sometimes start medication for anxiety. You can start tricyclic antidepressants, which really work not for anxiety per se, but they work on the GI tract to help with some of these functional symptoms. And there's a whole art to doing that, and that's beyond the scope of what we're going to talk about today. But sometimes you try these drugs like amitriptyline or nortriptyline. Sometimes you try traditional SSRI type antidepressant, and sometimes those work too. But the bottom line is you keep an open mind and you look for these kind of issues. So that is the deal there. Sometimes we have to say that despite exhaustive testing and despite exhaustive medication trials, we don't know what's wrong. It happens more often than I'd like to say, because medicine is very humbling. And the point is to this whole conversation that we don't always have the answers to every problem. And you have to keep trying. Sometimes you have to just keep trying. You have to keep looking for things and realize that the human body doesn't come with an instruction manual, and we don't always get to the bottom of these problems. But as long as we've done a very exhaustive look and we're seeing the patient routinely and trying to make sure nothing evolves over time that we're missing, because sometimes you do the whole workup, you find nothing, 6 months later something pops up, some new symptom or some new issue in the labs, and you figure it out then, and that happens. And it is humbling, and it is kind of intellectually difficult sometimes to make these diagnoses. But if you stick to it for long enough, either the disease declares itself, or you figure it out, or it gets better, or it gets worse. Those are the options. And hopefully it doesn't get worse. But the bottom line is that a case like this is complicated, and it's no wonder that she's seen several doctors, and hopefully she's found someone that she likes, and she's sticking with one doctor and trying to figure out this thing until the endpoint is reached. All right. So that's today's episode. It's more of an off-the-cuff thing, how I would work through something like this. And my approach is not everyone's approach, and other people may do it differently, or someone else might know exactly what this case is and get right to it right after the first chief complaint, and God bless them. But a lot of times there's a workup that has to be done. And I'd also like to say this is the first video episode that I'm doing, and whether or not you're even going to see this video, I'm not quite sure, but I'm going to talk about it on the audio part of the podcast. So I'm doing this in my new little studio that's only half built out. It's basically an empty room, and I'm trying to make it work. And the lighting is a little harsh, and I probably need to work on that a little bit, but I said, we're out of time. Let's just try it and see what happens, and here we are today. So hopefully I'll perfect the amazing video, and you can see my bald noggin in better lighting. But that is today's story. An interesting case and a trial of the video situation. And I might not be editing out some ums and thes and whatever I say that I'm not supposed to say, like that, because on video it's really much more annoying to edit things. So this podcast might be a little more raw when I do a video episode. And that's going to be that. It's going to be okay. All right. Here's the part where I tell you where to find the show. The Real GI Doc Show can be found on social media, anywhere social media is found, except for X, which is a platform of little use to me. That being said, you'll find this on YouTube. You'll find it on Facebook. You'll find it on Instagram. You'll find it on the TikTok. And I think LinkedIn as well. LinkedIn is a thing still. So you can find it there too. You can comment on these posts. I'll post some videos, hopefully, if this one turns out decent. And you can also send me an email, or you can use the link that will be attached to this episode somewhere to send an audio question. You can find it in the show notes also. You can send an audio question. I can talk about it on the air, virtually speaking, in a future episode. So if you have any good questions about GI, send them over. I have a whole bunch of questions I have to get through. Now that this little studio is going, I can hopefully get through them a little faster and keep you guys with some fresh episodes. And that's the story. I appreciate you listening, and thank you. And until next time, take care.